This afternoon sits on the platform of the EPI vehicle. So we want to see how the EPI program is performing in the country, and then we see how the malaria vaccine is going to ride on that vehicle. So I want to call on Mr. Katongere Deo to come and give us a presentation, and then we shall go to the panel discussion. Thank you.
Yes, good evening, everyone. I'm Deogracious Katongole, M&E for UNEP, Ministry of Health. As the chair has introduced, I'll also take us through the journey of malaria vaccine introduction, which began in March of this year. Yes, so. So let me tell you the rationale why we had to introduce this vaccine, basing on the country context and also basing on the data out there and the burden of the disease within the country. So we realized that as of 2022, half of the world population was actually at risk of malaria, with the biggest burden of sub-Saharan Africa, giving an estimate of 249 million cases annually, and of these, more than 600,000 coming from Africa. Meaning that Africa contributes 94% of these cases, and even 95% are fatalities. So malaria is more prevalent in children of under 5 years, accounting 80% of all malaria deaths, and basing on the WHO Africa region. 4 countries in Africa accounted to over half of malaria deaths worldwide, and these include Nigeria, DRC, Uganda, and Mozambique. So this makes Uganda one of the high burden countries for malaria. In 2003, Uganda was the 3rd highest contributor of global malaria cases at 5.1, and the 8th highest contributor to the global malaria deaths at 2.9. So of all the mortalities in the country for under 5s, malaria actually is the highest, with 14.6 of all under 5 deaths dying as a result of malaria. Even in our outpatient departments at health facilities, we find that the burden of malaria cases at OPD range between 30 to 50%, and admissions between 50 to 20%. The map shows the malaria incidence in the country, showing which regions have the highest burden. So you can see that the northern region, that's the Acholi and Western region, have the highest malaria burden in the country, and pockets of the Karamoja region, and less burden in the lower south and the central. So with this burden, the justification for introduction of the vaccine in the country. This vaccine was aimed at reducing the incidence and severity of malaria infections and contribute to overall childhood survival, as we have seen in the statistics below. In addition, the malaria vaccine introduction will further reduce the government expenditure and households out-of-pocket expenses, given that most of the households were spending significant sums of money in procuring drugs for malaria treatment regimens. In March of this year, we introduced the malaria vaccine in 100 and 5 districts across this country. These districts are based on the high incidence, and we can see the distribution having West Nile, Acholi, and Lango having the highest number of districts which are introduced because of the highest incidence of malaria in these districts. Districts with low incidence, we are post-deferred for introduction at a later phase, but potential is given to the high burden districts, which are 105 as of now. So plan to roll out to other districts once we have sufficient stocks. Given that, as we said, that malaria vaccine is part of the routine immunization, and we have, and the previous speakers already that as a country we have 14 antigens, which we inoculated to children, and these are the antigens we have: BCG, OPV, OPV1, IPV, DPT. In 2022, we introduced new vaccines, which include yellow fever, hepatitis birth dose, and mRNA vaccine. We can see that the new vaccine are not as performing as the traditional vaccines. As the program, we have the target of 90% for all vaccine antigens, so that we can, as our threshold, to help us understand that we are actually reached a significant number of children. Still, we can see that the malaria vaccine, MR1, MR2, MR4 are performing well because they're newly introduced, as we explain in the panel discussions. We have had significant strides in other vaccines, especially the HPV, the TD, the Rota, that actually exceeding the 90%. But more efforts need to be put in the new vaccines so that they can be able to pick up, so they can be able to saturate to the 90% threshold that we desire. For malaria vaccine in particular, by region, that these regions which are lagging behind when it comes to its introduction. I was explained that this vaccine is given 4 times to children. The first instance occurs at 6 months. That's when the child gets the first vaccine, the second vaccine at 7 months, and the third vaccine at 8 months. Then the 4th vaccine is scheduled at 18 months of age. So for now, our expectation is that since the introduction in March, we expect that the children have received the 3rd vaccine. We can see that the regions which are lagging behind when it comes to our vaccination, that only about only Lango and North Uganda actually more than 90% when it comes to MV1, whereas other districts are lagging behind less than 90%. And most performing regions are Bugisu, and Bukedi, and Chigezi. Even the regions which have the high malaria incidence, you can see that they're still lagging behind when it comes to their vaccine uptake. Still, our MV3 is so low because having a high dropout from MV1 to MV3, which as a program trying to close the gap. So it's a summary of the coverages for MV1, MV2, malaria 1 at 82%, malaria 2 at 47%, and malaria 3 at 30%. Malaria 4 is not yet due since we haven't yet made 18 months into the introduction phase. So this will be assessed 18 months after April of this year. The chart below shows the top districts and the bottom districts. We are having a differentiated model whereby giving support to districts which are actually lagging behind and giving them support, and also looking at districts that are actually performing very well to get learnings from them. So the districts in yellow are districts that are the bottom 20 in the region, in the country, and also the districts in red, in green are the top performing when it comes to immersion program. So with our target support supervision, we hope to reach out the lagging districts and also get learnings from the top districts. Our key challenges when it comes to the introduction, one was inadequate community awareness for the malaria vaccine, which actually did have actually demand creation. We did have a challenge of inadequate data capture tools during introduction that actually affected, led to some data losses. Also, some health facilities had limited use of microplans by health facilities, so they didn't map out which children actually eligible for this vaccine. And lastly, there was this limited cascade of knowledge to local governments. However, we have done mitigations in all these challenges by doing support supervision, which we have conducted, which the panel will discuss and take the team through. And also, currently, the new tools have been updated for malaria vaccination. So, going forward, we expect that all data shall be actually in the DHIS2. We also have leveraging on community-based services, the CHU program and the VHTs and SSCMs and CSOs to make sure that the message is out there for malaria vaccine uptake. And lastly, the lessons learned in this introduction. We realized that the regional FARO framework was really helpful for us to reach the districts and also giving that constant support to districts to help them optimize their vaccination. We also worked with the partners in this rollout, CHAI, PATH, even the partners, the districts, UHA, such that this vaccine can be able to be absorbed and rolled out. So this part has helped in planning and also coordination at district level. We also realized the impact of microplans at the district. So districts which had up-to-date microplans reached more children than districts which didn't have up-to-date microplans. Also, proper plan for data management at introduction level is always key for the teams to actually be in position to account for efforts during introduction and also subsequent rollouts. Thank you. Yeah, thank you. Over to you. Thank you.
Thank you, Deo, for giving us the highlights of so far. Colleagues, as you appreciate, malaria is the biggest cause of morbidity and mortality in this country. And anything that would impact on the prevalence of malaria would definitely be good news and would reduce on the cases in the hospitals, would reduce on the hospitalization, and would reduce on the death of especially below 5 children. And therefore, with the introduction of this vaccine, we are very excited that we should be able to impact on these parameters. I'm going to invite Dr. Ombeva, and as a panel discussion, Dr. Ombeva, I'm going to ask you to focus your discussion on these 4 questions. 1, tell these members, how does the malaria vaccine work? In brief. 2, why do we restrict it to only children below 2 years for now? 3, what are the public health outcomes expected when we have a successful malaria vaccine rollout? And lastly, what do you see in 1 year's time from now as far as the trend of the disease and the trend of the vaccination program? Dr. Mbeva, the floor is yours. If you can use 7 minutes, I will be very happy. Thank you.
Thank you so much. Thank you, colleagues. My name is Umbeva Malande. I'm a vaccinologist and a pediatric infectious disease specialist. How does the vaccine work? Now, you know, malaria, when a mosquito bites you, it releases malaria parasites into your blood. There's a very short window, about 30 minutes, when the parasites then leave the blood and enter the liver. Any successful malaria interventions must target that moment, because once it has entered the liver and multiplies there, a lot of the sporozoites and the forms of malaria parasite stages and a particular stage of development are released into blood, and then it becomes a very big problem to contain. And that is the window that the vaccine targets. That small time when the mosquito has just released into the blood, that short window of about 30 minutes before it enters into the liver. So there are malaria forms that are called sporozoites, and onto them they have a protein that is called the CSP. It is that component that has been removed and added onto a hepatitis B vaccine carrier, combined together to form the malaria vaccine. And this is contained in the two types of malaria vaccines that were mentioned there, the RTS and the R21. So the hepatitis B component just helps to make the vaccine immune response stronger. It's an adjuvant and stabilizes the vaccine. That's why we say if someone reacted to hepatitis B vaccine, then we don't want to give them the malaria vaccine, because that component can accentuate any reaction in this particular patient. So basically, this particular component therefore targets the sporozoites just before they enter the liver. So that is really how the vaccine works. That's the point at which it targets the malaria life cycle. In the studies that were done in Ghana, in Kenya, and Malawi, the malaria vaccine was shown to reduce all-cause mortality. In fact, this is really the biggest message around malaria vaccine. It reduced all-cause mortality by 13%. Now, this is 13 may look like a small figure because we are used to passing our students when they get 50. So every time we see 13, it looks small. But when you are talking in public health terms, when you are looking at a disease that kills millions, a 13% reduction in deaths is a very big reduction. It's a big, big reduction. Because remember, when we are talking about all-cause mortality, we are saying a child has come to a hospital for whatever reason. Maybe they came with pneumonia, maybe they came with diarrhea, maybe they came with malnutrition. In areas where the vaccine was reduced, all deaths, it doesn't matter what is killing children under 5, were found to reduce by 13%. That is a massive reduction in public health terms. If you are having, like, let's say, 1 million children dying, you've already saved 130,000 just by introducing the vaccine. We haven't talked to malaria deaths. We just talked all deaths, and that's a huge reduction. But when it comes to malaria deaths themselves, severe malaria deaths reduced by 30%. And then the uncomplicated cases progressing to severity reduced by 40%. In areas where malaria only occurs in seasons, those batches of seasons, reductions to severity and deaths occurred, reductions up to 75%. So when we are looking at the second question that deals with public health significance, the malaria vaccine has been seen to have such enormous contribution in Kenya, Malawi, and Ghana, where they're having longitudinal follow-ups of those particular children. Now, when you think about why do we target children under 2 years? 2 good reasons. One, because malaria has its biggest burden in children under 5 and in pregnant mothers. When you look at deaths in children under 5, majority of these deaths are actually concentrated in the neonatal period. Then the second biggest part where they are concentrated is under 2 years. It's in the under 2 years where the malnutrition is higher. is in the under 2 years when the vaccine preventable diseases are higher. That's really where the deaths are concentrated. And it's the same thing with malaria. So when we are looking at reducing burdens of deaths, that has to be the area of focus. And then, so where do we go 1 year from now? What do we think will happen? Already we are seeing some 3 very good things. Not only are we seeing reductions in deaths in all-cause mortality in children, but malaria vaccine has come with another very good thing. For the years I've been very close with the immunization program, close to 15 years, of all vaccines we have rolled out, the malaria vaccine has been the best received vaccine. Not just in this country, but in all countries. I think coming to about 30 countries that are now preparing or have rolled out the malaria program vaccine. Why? Because this is a disease that everyone knows. There's no one who can pretend they don't know about malaria. Either they suffered, their relative has died of it, or they even have someone who is sick, or they are swallowing malaria medicine at that time. We all know about it. And we think because the public is very familiar with the disease and they know how dangerous it is, that has really improved the rate at which it has been received. The reception has been good to the point where adults are asking for the vaccine, which is being given to children. It's the only vaccine where we hear adults telling us, we want it. Where is the vaccine? In Kampala here, very many people asking us for the vaccine because they are saying, why did you leave us out and go for the other districts? But remember, the vaccine has been rolled out in only 105 districts, which are moderate to high burden. And that's why you hear people asking, why is it that you left out Kampala? Why did you leave out Wachi? So it's because epidemiologically this is a low, it's not classified as high or moderate spread zone. So in 2 years from now, first of all, like I said, we're already seeing gains, but we will see reduction. But from an immunization and public health standpoint, I think we will see a reduction in the fears against vaccination, what we call hesitancy. I really hope our measles vaccine, measles 2, that has been performing very poorly, can hang on to malaria dose 4 when the parents come for their 4th dose, and we'll be able to improve the vaccines that have been a big problem for us at 9 months and at 18 months. Thank you so much.
Thank you for giving us that science. Dr. Mbeva is from the academia, and he has given us the science, how the vaccine works. And just to add on that a child to be fully protected needs 4 doses. But most importantly, the first 3 doses are the most crucial at 6 months, 7 and 8, and the last one at 18 months. Getting 1 dose, as you have seen in the charts, where people are getting the first dose in 80s and then they drop, that does not protect our children. And because of that, I'm going to ask a pediatrician to come and tell us from their perspective. Pediatricians are the ones who interact with these children. They are the ones who see the big burden of the disease. So Dr. Sabrina, who represents the pediatricians, I'm going to ask you 2 questions. One, malaria vaccine requires a coverage of about 85%. And that is what the government put in the strategic plan to achieve 85% of 3 doses. In your view, what can be done to increase the coverage? You have seen it is now at 30%. The 3rd dose is now at 30%. What can be done to increase the coverage? The second question is, do you think professional councils have a role to play, and what can they do to improve the uptake of the vaccine? Over to you, Dr. Sabrina. Or you can speak from there.
Yeah, thank you so much. Those are really great questions. First of all, I'm privileged to be part of this meeting as a pediatrician, but also as a mother. And I'd like to say that the malaria vaccine is one of the most important vaccines that has been introduced in the past 50 years. because malaria affects each and every one. I work on an infectious diseases ward at Mulago, and one of the saddest things is to see a baby die of malaria, a preventable death. These children die because they come in late, they come in with severe anemia, they come in with cerebral malaria, they come in because they have malaria and kidney failure. So no child should die of malaria. I think the question that was asked to me specifically was, how do we increase the uptake? I think it's a multifaceted approach, and also we need to consider giving the malaria vaccine to Kampalans. Kampalans are big spenders, but also there is a big population of people in Kampala who live in low-lying areas that are affected by malaria. I can assure you, if that vaccine was truly universal, being given to every child in this country, there'd be no discussion of should we get it or shouldn't we. That besides, I think there's a need for community engagement, and with community engagement, I mean addressing the parents who bring the children to the hospital, talking on local radio stations, making sure that church leaders and mosque leaders and Hindu temple leaders are talking about the malaria vaccine, just like we talk about the measles vaccine, just like we talk about the BCG vaccine that's given at birth. And so we need to integrate the malaria vaccine with existing services. Just like when a child comes to the hospital and mom has come in for, let's say, weighing the baby, we usually ask for the card and make sure that that child does not leave without being vaccinated. I teach at Malaria University, and I teach the students that every child needs to be vaccinated. However, I get challenged as a pediatrician when the malaria vaccine is not available for the pre-service trainees to see and even to provide. We need targeted campaigns, yes, but as you have seen from Dewo's presentation, the highest level that we have gotten to is 82%. That is 3% less than what the government targeted for all the vaccines. So just to reflect, the malaria vaccine one has gotten 82%, and then the second dose is 47%, the third dose is 30%. I don't know what the fourth dose is going to be, 2%? Ladies and gentlemen, you are the champions who we need to go back and talk to the villagers. We need to go back and talk to the parents and make sure that the children get those vaccines that they need. Of course, I know that combining the malaria vaccine with other interventions is what is going to work. The malaria treated nets are so important. Spraying the bushes, cutting the bushes, all those things are going to work. Chemoprophylaxis for malaria is also important, but we know that those who are most at risk are children below the age of 5, and they need to get their vaccines. A lot of times parents call me and they say, should I give my child the vaccine? My baby is 3 years. I really need to take my child. And my answer to that question is usually, first wait. The vaccine was bought for children below the age of 2 years. However, I think that at this point, if we do the approach that we did for HPV vaccine and other new vaccines, I think it would work. That we do a big catch-up campaign for any child below the age of 5, make sure they are covered, and then we proceed to the age-related 6 months and all that. What can we do as pediatricians? I think as pediatricians, we are doing a lot, and I'd like any pediatrician in the room to please raise their hands if you're in the room and you're a pediatrician. People, please clap for these guys. We are the people who talk directly to the mothers, who encourage them to vaccinate their children. If we as pediatricians are not convinced about this vaccine, I can assure you the vaccine will not be given. Parents trust their pediatricians. And so if you ensure that the pediatricians understand this vaccine, then the vaccine is going to be more enabled. At the last Uganda Pediatrics Association, we had an entire session just talking about the malaria vaccine, which was amazing. And the thing that surprised me is that some pediatricians were not very willing to prescribe the malaria vaccine. They had questions. But during a peer-to-peer support program, we were able to explain, just like Dr. Ombeva did, how does the vaccine work? What are the side effects? The misinformation and misconceptions are what are delaying or curtailing the malaria vaccine uptake. And so we need to remove those fears. The side effects, as far as I'm concerned, include pain at the injection site and a slight rise in the temperature. But there's a lot of misinformation. I've always given an example of when you're entering an elevator or a lift, there are so many little words on the side that, you know, the lift could fall, the lift may lock you in, and some lifts in this city have locked in people. But you still take the lift, don't you? So let us trust the vaccine. Let us ensure that we tell the parents the real truth, that the vaccine is going to protect their baby from dying 13% of the times, and also ensure that they do the other things, including covering the baby with a mosquito net. Not an old mosquito net, but a new one that is impregnated with insecticide. Last of all, it's important to ensure that we include the community leaders in planning. Dr. Posi Mujenis and also Deo said that the people who are doing the best, the districts that are doing the best, are the ones that have had very good micro-planning. Let us all plan together. Let us not plan in silos. As we continue to talk about unification and engaging everyone and the CSOs and everyone, let us plan with them. But also let there be funding, enough funding in the budget to promote communication. Communication is key. And if we don't communicate well, people are not going to learn. Let us translate those communication messages into every single language. I'm not sure about all the 1,105 districts, but I hope that the communication was given even in the local languages. For missed opportunities, if a child missed at 6 months, can we give the vaccine at 7 months, then 8 months, then 9 months? Let no child miss any vaccine. I'll stop here, but I can assure you I have so many other things. The last point is on data monitoring. For those children who received the vaccine, are we monitoring to see that their malaria rates are going down? This could be a very good success story. If we see that the malaria has truly reduced in those 105 districts, then that is a cause to celebrate. And then we can spread the vaccine to also the other districts. Thank you very much.
Thank you very much, Dr. Sabrina, for those inputs. Dr. Sabrina, you have mentioned something that could be carried forward, big catch-up to clear the backlog if you want fast track and get quick results to impact on the number of cases occurring. Then she also mentioned something important for us who manage hospitals to institutionalize screening for the vaccination status at every outpatient, every ART clinic, every inpatient, everywhere a child below 5 appears, it should be screened for immunization status and taken to the side of immunization so that the child doesn't leave the facility when he's not vaccinated. I think those are very important points. Now let's move down to the implementers. We know when these vaccines come, they go to the districts. From the districts, they go to the facilities. So we are going to hear from one of the districts, a district health officer, who is actually among the 105 districts that have been implementing this rollout of malaria vaccine since April. So I'm going to invite the district health officer Masaka, Dr. Faith. And Dr. Faith, I am going to give you just one question. In your view, what has been your experience in rolling out the malaria vaccine, and what has been the accomplishments? What have been the lessons learned you think you can export to other areas, and what has been the best practices? Have there been any innovations that you think can help to increase the uptake of this vaccine? Dr. Faith Nachinji of Masaka District, please take the floor.
Thank you, moderator. Good afternoon, members. I'm very glad to be part of this conversation. For Masaka District, at the entry, we had our leaders oriented and they made commitments. And for example, the RDC committed to give us airtime, and every time we inform her on time, would go and talk about the vaccine to reinforce the information to our community. After the entry, we had a regional TOT for the DHT, but also we rolled down to the trainings to the sub-county level, where we engaged health workers and the VHTs at that. The reason why we had the VHTs, they had to understand the schedules, the relevance, and also help us in inputting into our micro plan. Because at that point, we had extra outreaches where they would suggest where the locations, because they knew the community well. So they were a good resource in inputting where we would put our outreaches. Then as we scaled down, as we rolled out the vaccination, it happened at a time when it was routine ICHDs, those are integrated child health days, and that was kind of a shadow. It masked the importance of the vaccine because mothers were used to this routine, though we tried as much as possible to also orient them. With the support of the IPs, were able to get more extra outreaches, to improve access to these vaccines. However, when we started, earlier on, we had partners that had supported us in our immunization program, like one that identified peer mothers. And we also leveraged on the past that, we still have our community peer mothers. So we use these peer mothers to mobilize for these targeted outreaches, extra outreaches, and that also gave us a good coverage at the beginning. But we also engaged the community-based organizations because they were already working in the community and they were used to the communities, and they also helped us sensitize the communities and mobilize them for the vaccine. Yeah. So basically, that's the experience that we had. And what has made us progress? One, we really use our data. It's the data that we use. Even when partners come to us for support, we assign them areas. We are focused. We don't just send them to the entire district. We are purposed. We send them to low-performing communities, and that's where we begin from. We use our data and assign them to weak-performing facilities. But we also, in utilization of our data, we always do performance reviews to assess how we are performing and compare notes, which sub-county is performing well, why, and we share lessons for improvement. Apart from that, we have a vibrant DHT team. During the micro plan, people share their schedules. And even in these additional outreaches, people share their schedules to a point that every time we check the schedule under DHT, we assign DHTs to different sub-counties. So at any one time, a DHT goes and monitors if that outreach is happening. Sometimes people report that they are going for an outreach and they don't go. So this time round, we monitor and check on whether the outreach has happened. And indeed, initially people were dodging. They would tell you, we shall be here. You go there and they are not there. But when they learned that we monitor those outreaches, they are always there, and they give us a comprehensive report, not only the numbers, but also tell us where it has happened, the numbers, the challenges, and the mobilization strategies that they used. Yeah. But we've also had very, very supportive partners. We have one that was purely for behavior change communications, and it used a lot of different strategies that we had not even learned about, like engaging these people who speak at ceremonies. They also engaged them, told them about the vaccination schedule of children, not only for malaria, such that they go and disseminate that information at different occasions, like parties, like we know those ceremonial people. So they were also engaged. That was a strategy that we had never thought about, but this partner came up with that. But also partners have also supported us to do regular targeted supportive supervision, much as we integrate, but sometimes we may have to go specifically to check whether the people are doing the right thing, whether the data is also of quality. So we also do data quality assessments with support of our partners. But again, even before the malaria vaccine introduction, we had a weekly tracker of EPI. For all our key indicators, we have weekly trackers, like for MCH, we have EPI, we have, and facilities, we have a tracker and a tool where they give us the numbers they are targeting that week and how much they've achieved. And my ADH or MCH is very keen. She will always give quick responses every time they post. They'll tell you, this facility, you've not been able to get this much. Why? She always puts them on target, and they even give, there is a column for vaccine balances. She would know now. You don't even have vaccines here. You're reporting zero. She's always, she gives quick responses. She's very vibrant at that. So people are used to her. We have that weekly tracker, but we also have a defaulter tracker. So that defaulter tracker also feeds into the weekly targets. If you see that these children have missed their vaccines, you expect them to either meet them at an outreach or at facility level, and it's part of the targets of the week. And if it's not met, they reach out to the peer mothers to identify those children and mobilize them maybe for an outreach, that targeted outreach, or bring them back to the facility. Basically, that's how we do. Thank you so much.
Thank you, Dr. Faith, for those good practices. Those of us who have been in the field, we know those are some of the very, very good practices once institutionalized, monitoring the outreaches, because in immunization, outreach is the major source where parents can access vaccination. So monitoring the outreaches is a very, very important practice. Ensuring people are following the work plan is very, very important. And having partnerships, because the district cannot do it alone, having the partners support. And since you have talked about having the partners, I'm going to hear a CSO to hear how they are doing it in terms of supporting districts to increase uptake of the vaccines. And CSOs stand in the middle of the public, clients, and the government which provide the service. So I'm going to invite Mr. Simon Njala to come and share with us experiences as a CSO. Do you think it is important to work with the community for the malaria vaccine rollout? And as people who work with the communities, what are the challenges? Question 2, how can we better work with the community? Question 3, what challenges do you foresee as we move towards increasing the uptake of the malaria vaccine? And lastly, what do you recommend as a way of solving some of those challenges? Mr. Simon Njala, the platform is yours.
Mata Mata is a greeting in Karamojong. Canon Simon Peter Ijala from Karamoja. We are partnering with Ministry of Health, the districts, local governments, and PATH to be able to create demand for immunization. But on top of creating demand for immunization, we are trying to ensure that the communities can be able to trust the vaccines that we are giving out through the technical people. And also, very importantly, to be able to debunk the myth that could be there in the communities. There are a number of questions here. What are we doing to support the districts? We are doing a number of things to support our districts. We are aware that we have the micro plans, and so that is one of the things that we really look into. It's a very important tool for us. When we get to the communities, we have to be able to link up with the health centers who are in the communities. We work with a number of structures in the communities. We work with the crowd leaders. We work with the community-based organizations or MDD groups. And they have been very, very important to the work that we do. They have helped us a lot. For example, in Moroto district, a place called Lotisan, we have a kraal in a place called Natireng. Natireng is in Lotisan sub-county. The kraal leaders did a very commendable job. During the integrated child health days, they were able to mobilize. The people who stay in the kraal with them. And in that visit, we saw 20 zero-dose children vaccinated. We saw 210 under-immunized children vaccinated. We saw about 80 people, children, receiving deworming and vitamin A for the very first time. But also we saw 15 non-pregnant mothers and 10 pregnant mothers receiving TT. We also saw 102 people in the kraal being screened for malaria, 101 screened for HIV/AIDS, and then 210 screened for nutrition. So kraal leaders are a very important structure for us in Karamoja. They have committed themselves to be able to support us in ensuring that we do not have this issue of children not being vaccinated. Of course, in Nakapiripirit, the MDD groups, as you know, that we love dancing, we love music in Karamoja. I don't know other places, but it is something that we love a lot. And music and dance. We have a donga, we have a lot of music. Is very important for us in ensuring that we reach out to these children. So we were able to reach out through MDD in Nakapiripirit. In 2 months, we were able to reach out to 56 zero-dose children, 360 under-immunized children. And so we can see that really community is very, very important in the work that we are talking about, ensuring that malaria vaccine is taken up. What have been some of the challenges that have been there in our work? There have been a few challenges, and what the mothers tell us is that sometimes they forget. Sometimes they forget about taking back children to the health centers. Sometimes they have competing priorities. They start thinking about, should I go to look for food for the family, or do I go to the health center? So that has been one of the other issues. Also, issues of long distances to facilities is still a challenge. We are happy that the president has promised, as in his campaign, in his manifesto of protecting the gains, to be able to give us more health centers. So we hope that this will be really come handy in helping us. The other issue is around the mobility of our people. Our people in certain periods of time move to neighboring districts. They move to Lango, they move to Teso, they move to Acholi. They move there to provide labor in exchange of food. So when that happens, sometimes tracking children who should be able to receive different doses becomes a challenge. Of course, the other issue is about our poor roads. Poor roads to health facilities is another issue, which we hope that now will be handled. There is an issue about how can we be able to work better. Having worked with the VHTs, LC1s, having worked with the CBOs to be able to do MDD, having worked with the crowd leaders, the influential leaders who happen to be religious leaders, we think that whenever we get to the field to be able to create demand, we should go with people who are ready to vaccinate. That every activity we go to, if we are going to do crowd leaders dialogue, we should go with somebody who has vaccines ready to vaccinate, not to create demand and then later on tell people that go to the health center. We think that it is important to be able to vaccinate there and then. The other thing that we think that we will continue to do, instead of tracking the cards of children at home, which sometimes is a challenge in Karamoja because of issues around nutrition. When there are issues around nutrition, sometimes you find people have more than one card. So sometimes can be challenging. So we are thinking we need to be able to track them at the health facility. And then we take the information to the villages, to the LC1s and the VHTs to be able to mobilize them so that they can be vaccinated. The other thing that we are thinking about is outreaches. Just like I've said, we have long distances to health facilities. We have had to reach areas. So it is very important to be able to go to them. Of course, facilities have some money for doing outreaches through PHC. But what is clear is that the money is small. They cannot be able to reach to very, very distant places. So it is important that we really reach out to those hard-to-reach areas and be able to vaccinate the children. So really, our recommendation is that let us continue to work together with these community structures. They are very much willing, they are very much positive to be able to help us in this campaign, in the campaign of ensuring that we do not lose children, we do not lose mothers, we do not lose Ugandans because of malaria. So we want to continue as CSOs to work with these structures. I'm happy about peer mothers. It's something that will definitely continue to pick up as well in Karamoja. to engage them so that, but also really we recommend that government does their part, because we do not want a situation where we have to go every time. We recommend that government does their part to be able to ensure that there are health facilities that are near the people, that there are enough health workers. We have a big challenge of health workers, but also issues around the road infrastructure. So really, these are things that should be able to help us do our work as CSOs. But of course, we continue to request support from all stakeholders in ensuring that we're able to do the work that we've been given. Thank you so much.
Thank you very much, Simon, representing the civil society. He's mentioned a very important point of harmonizing the demand generation and service delivery. It has been noted even by other organizations that when you mobilize people, you refer children for immunization, and you don't place immunization points very close, people forget after a week or so, and the immunization or the referral goes to waste. So that's a very important point that we all need to take home. And the other point he has talked about is making sure that we line list children who have received one dose and are missing the subsequent doses, and we give the list to the community leaders, LC1 chairperson, VHT, for tracking these children and ensuring these children complete immunization. Time is not on our side. It's already 6 and we need to be out of here within the next 10 minutes. I'm going to ask Dr. Grace Chuanuka, who represents the private sector, in the 2 minutes to share with us your experience of the private sector engagement in malaria vaccine uptake. You can give us your experience from the private sector. We compare with what is happening in the public sector, and what can we do differently with the private sector to improve uptake? What can we do differently to use the private sector structures to increase uptake? Kindly do it in the next 2-3 minutes, then we can ask the House to give us questions and we'll be out of here. Thank you.
Thank you. I don't want to be controversial, so I may not take 2 minutes. I'll try and say what is important. Because we know we have a mixed health system. And if you look at the studies over the last 5 to 10 years, you'll know predominantly the private sector provides services in this country, especially in urban centers. So it may not be appropriate for me to try and squeeze all of that in 2 minutes. But what I can say from our experience, it's been a mixed experience because in fact, even if you hear from the other presenters, the inclusion of the private sector from the outset has been really limited. And a lot of us in the room will have deja vu from the COVID experience, where uptake of the COVID vaccine was not what we desired because of the timing of the inclusion of the private sector and the audience given to the private sector to understand the challenges of administering that vaccine when we wanted it to be taken up and the numbers were starting to stall and to stagnate. That said, when we look at the number of sites in the private sector that have been included in the rollout, again, the number is very low because of the approach and the strategy of predominantly using PNFP and public facilities. So maybe I'll just talk about building on some of the issues that the other speakers have talked about around myths and misconceptions. Because similarly, consumers come to the private facilities and say, do you have the vaccine? And we say we don't. But now asking them to go to another facility to look for it that may not be accessible to them for any number of reasons makes people either forget that they actually even wanted the vaccine and they move on to other things. So the challenges really focus on some health system strengthening gaps that we have as a country, in that as we're planning for the strategies to roll out a lot of these vaccines, we don't consider the private sector from the outset. We think about it somewhere down along the lines, either when things are not going so well, or when now we have so many vaccines where they're about to expire, we need to roll them out, so then we go to the private sector. And that in itself causes some of the challenges that we might experience down the line as a country. Fortunately, the CSOs have talked about creating demand. I know predominantly we've initially been relying a lot on CSOs and development partners to catalyze that demand. And that demand, when it comes to people choosing where they go, for that demand, when that demand is catalyzed, that's where we also need to really be intentional in who we're partnering with in the private sector, whether it's strategically located or whether it's places where mothers are already going for vaccine. Because if you look at our experience with UNEPI, you'll notice that some vaccines move faster than others. Obviously, the ones that you get at the outset when you've just had the baby, if it's your first child, yes, you're going to be a little more diligent. But when you're looking at other children along the value chain, the ones that are around 18 months there, you find people start to drop off, and that's why we're seeing these numbers, because yes, people have competing priorities. People are mobile. You'll find they'll have their child in the village, then they'll move to the city for work because they really only went to the village to have the baby. Then they're moving to where they do their work and they transact for their day-to-day sustenance. There's also limited knowledge about the vaccine. I think the other speakers have talked about that. That minimal understanding means that we have late buy-in, and that's where we open the door for those misconceptions and myths, and TikTok and Instagram are working very, very hard. They're actually working much harder to communicate the myths and misconceptions more than we are as a health sector. So that confusion of who has it, where can I get it, is it really for me, and is it really safe? That's where we need to talk about a different approach. We need to make sure that we look at the whole health system holistically, not in silos, because that is where we're going to face more challenges down the line. And that's why I'm talking about inclusion from the outset of the private sector. We need patient education. A lot of times people go to the health facility, for private facilities for other things, whether it's family planning, any other reason. But if the private facilities are well informed on the malaria vaccine, they know who's got age-appropriate children to consume these vaccines. That is where organizations like the Uganda Healthcare Federation, where I work, that's what we do. We make sure that the private providers understand what is the value proposition of that vaccine. Why should you think about it? Yes, you've come today for a cough, but we know you have a child. Maybe you can come back, because that cross-selling of services is done more predominantly through private providers. We need to also look at partnership that is meaningful. I know we have a multisectoral partnerships department in the Ministry of Health. I think we need to leverage that more, because when we work together, like I said, people have deja vu of COVID and what happened with the COVID vaccines, in the sense that if we don't learn from these experiences and plan to work together and meaningfully partner with each other, we're going to keep in this cycle of coming in with very good innovative solutions to our mortality and morbidity, and we're not going to be able to harness those benefits holistically because we're not learning from the experience of including the private sector from the outset. So that mindset shift is what we really need to work on. Thank you. Back to you.
Thank you, Grace, for giving us those views and points and proposals. Definitely, we know private sector is a very big player in the health sector, especially in the urban settings. And what is interesting is that malaria vaccine is available in a number of private health facilities. In the districts where the government has not piloted, rather has not rolled out a vaccine, this vaccine can be accessed at a cost which is affordable, and I think to be prudent for those of us who stay in urban settings like Kampala, Mukono, Entebbe, which doesn't appear in Katongole's map, we should be able to access this vaccine. And also the private sector helps us a lot, complements what government is doing in most of the districts. They are part of the static facilities. They offer immunization services and they partner with the government, because the government offers refrigerators, offers the vaccines and other tools for documentation, and the private sector provides the setting, the manpower, the infrastructure, and provides the immunization services for free of charge. So having heard from our panelists, 5 panelists, I now open to the members, to the colleagues. We use 5 minutes to raise about maximum 5 questions, and then we shall conclude it. Somebody who moves with a mic, Please ask one question. You can give a compliment, you can give a comment or a question. We are not limiting it to questions, but it should be brief to one comment, one compliment, or one question.
Cynthia.
Yeah. There is a guy behind there. There's a gentleman behind there.
Thank you. My name is Chukuma, Dr. Chukuma Omeokonko. I want to thank the panelists for a wonderful presentation. And my question goes to the person that presented on malaria vaccine uptake. What's your experience in communicating this data to the mothers in the rural area when you talked about the 13% reduction in all cost of deaths? Most women would think that once they receive the vaccine, their children will not get malaria anymore. But we know that's not the case. Just that the severity and the outcome is moderated. So how do we sell this vaccine to them without raising their hope? And they come back to us and say, what you've told us is not true. Our children are still having malaria. So what's your experience communicating that community? Thank you.
Good question.
Can I go on?
So keep note. Yeah, that's from Beva.
Have the
Next,
mic.
go move like that.
Have the mic. Thank you. My name is Mabel Musa, for Status Officer Masaka City. I have two concerns. One to M&E officer. From the presentations, I'm seeing malaria may be like the DPT where we've been struggling. And if we start struggling like this, I'm starting to think it could be a policy issue. Reason, at 6 months, when you look at the schedule for our children, it is in routine. Now, it is after again 4 weeks, 6 weeks and so on. Can't we design a program that when the mothers are being brought, it is matching with the next vaccination? Because from what I've heard from the pediatrician, how the vaccine works, it is not on time. It is not on time. So can we schedule to ensure that it complies to when these mothers are coming? Then the second one is on misinformation. In our execution of the campaigns, the COVID and so on, during the Child Health Days, those who are against malaria are the professionals. So my thinking is, I think it is the professionals who should be changed first. The mothers are already receiving the what? They are ready to receive. Actually, there is even a professor with a school who says does not believe in vaccines. So we also, as a city, we are trying to do it to see how either we use any form that he can understand. Otherwise, to me, in the academia, I request that the students who come out, they should be already with that knowledge, that we deal with the few who are likely to confuse what? The parents for the uptake. I submit.
Thank you. Next.
Thank you very much. My name is Rebecca Nabukenya. I'm a student of Master of Public Health at Makerere. I'm also a community educator at Baylor Foundation, Uganda. I really appreciate the panelists for this session, which has reminded me that community engagement is really key. And I want to implore us to always endeavor to engage all stakeholders in all stages of the program, right from the pre-program stage, implementation, and even during the program and at the end. I wanted to re-echo what presenter there from private sector was talking about. I imagine a scenario where they have been involved right from the beginning or just before the program starts, and what picture would have at the end of the implementation of the program. Thank you.
Thank you. Next.
Yeah, thank you very much. I think I'll echo what our colleague with a Nigerian accent from the other side, I think, was talking about. I think, and addressed, also addressed by Grace from the private sector, the messaging. Maybe this will be a sort of professional that malaria should not kill. It's only the complications like severe anemia, acute kidney injury, and the like. So we need to tell the parents, the caretakers, that while we are giving the vaccine, it's just to prevent these complications, the severe form of malaria. Otherwise, I've seen from the countryside that people have had the vaccine 2-3 doses, they've had a few attacks. So they're beginning to say, why? So I think part of the message we need to emphasize is that they need to use also the other protective gears like nets, taking the child early, so that we try to strengthen malaria vaccine being new on the scene after very many years of trying to discover the same. We need to see that every loophole is bridged. So telling the mothers that it prevents the severe forms is very, very important. I need to pick up from the other point where I think it was Sabrina talking of targeted vaccine. First of all, in Kampala, where it is, the prevalence is very low, it's 1%. It's not all uniform. If you went to Katanga or to Namuongo there, the prevalence is much higher, more than 5%. So I think we need to think out, if monies were available, that we go into even those where the prevalence is in Kampala or in urban areas where we think they are rich, they can afford to buy, but the poor are there and the ones who go to the pediatric ward. So I think we need to target even in the urban areas, foci where malaria is more prevalent than what the national prevalence is. I submit.
Thank you. I hope we are done with the questions. I'm going to ask.
Thank you. I had one more question.
Oh, yeah?
My name is Daisy. When she mentioned that the professionals are having a challenge, I think we need to explain why these sporozoites will be working while the natural exposure has not been working. Because if a child or someone has previously been exposed to this malaria, the sporozoites, and their immune system over this long has not really been helpful, how come these sporozoites, what's special about these sporozoites that will work more than the natural sporozoites? Thank you.
Thank you. I'm going to move you to bring it back to the high table, and I will ask to respond from that side. If the question directed to you, respond. If nothing, push to the next.
Thank you. I think my main is just to appreciate people have understood what I was explaining, so I don't think I had any questions. But
Thank you.
So I'll respond to the question about natural immunity versus the enhanced immunity with the vaccine. You don't want your child to be an experiment, because if your child gets a severe form of malaria, they are more likely to have complications. But if they've been given the vaccine, then their body has been primed to get a less severe form of the disease. And that's the message that we'd like you to go with. Giving the vaccine to every child is likely to reduce on the severity of the disease. And I'd like to think that Dr. Myers-Lugemwa was supporting me to ensure that the vaccine is universal, not to a few, but to all, so that every child, whether my child or grandchild travels to Gulu, if they've been vaccinated from Kampala, they will be protected. That the vaccine should be for everyone, not for a few. Thank you.
Thank you. Dr. Mbeva?
Thank you so much. I just need to maybe clarify and emphasize the concern around 13% all-cause mortality protection. Remember, that is for all diseases of children who were found in the study area. But when you're looking at malaria itself, effectiveness is around 40%, 37 to 40% for all the vaccines. There is another 60% to catch up, and this is provided by nets and is provided by chemoprophylaxis. When mothers are pregnant, you see we give them Fansida. There are children who receive chemoprophylaxis who are in special groups, like those who have sickle cell disease and others. So we are saying that identify the malaria early and treat it effectively. That is called effective case management, so that they then don't spread to others. And then sleep in treated mosquito nets. That usually provides about 30% protection. If we treat those who have malaria, identify them early and treat early. Those ones who don't have, and all children in general, sleep in mosquito nets, and then we vaccinate them, our collective protection rises to around 80 to 90%. So the message for malaria vaccine in communicating is that the vaccine alone will not keep the malaria away. We still must sleep in treated nets. At least the children and pregnant mothers must be in the nets. And then if you notice your child having any sign of malaria, fever, refusal to feed and all those signs, vomiting and the rest, quickly rush to the health facilities so that we quickly identify and treat those and reduce the spread. So that has to be the message. It must be collective. Effective case management, identification and management, sleeping in treated mosquito nets, and the vaccine. Thank you so much.
Yeah, thank you, Dr. Mbeva. I just want to respond to one of the questions, which was talking about the scheduling, the programming of 6 months, 7 and 8, to schedule in line with the mother's visit to the health facility. The vaccines which are available, the two vaccine brands which are available, when being tested, they were found to be effective beginning with 5 months. So anything given below 5 months will not be effective. They were effective from 5 months, and Uganda chose to begin at 6 months, 7 months and 8 months, and to give the last dose at 18 months to coincide with MR2, where the mother is already bringing the child for the second dose of MR. So this scheduling is like dictated on by the clinical trials. The science found that this is the best time you can protect the child and you don't need to wait. And you cannot give it earlier because it will not be effective. And the last message in this presentation, because I don't think there were questions for my colleagues on this side, the last question for this presentation is that in a summary, we want to say malaria vaccine is effective in reducing the severe forms of malaria, in reducing hospitalization and reducing death. However, it's not 100% effective alone. So it needs to be combined with other measures of malaria prevention in order for it to be even more effective. So mothers who have their children vaccinated need to continue making their children sleep under the net and attending other malaria preventive measures. It has come in as a top-up of other measures, not to replace the other malaria prevention measures. And on that note, I want to thank you very much to have chosen to attend this session of malaria vaccine. And I want you to join me in thanking these panelists. I think they have done a great job. So thank you. And if you have any other question, we can meet in the corridor and we can answer more questions about how the vaccine works and other strategies on how we can increase the rollout. And thank you. I invite the panelists to come forward for a good photo, and then the session is closed for this meeting. Thank you very much. I hand over to the organizers.
The cameraman, come for the photo. Members, please give a big hand clap to our chair for the session. And I think we all deserve a big hand clap for keeping the audience engaged. We had over 80 people for this last session, and much as we were able to start late, we have been able to cover all the sessions I'd planned. So tomorrow, our day 2 for the main conference is on. We shall begin here in the main hall, Victoria Hall, exactly at 9. And before that, we shall have an opportunity to hear from what was discussed in all the 4 breakout sessions. So if you come early, you benefit from that, so that by 9, we start with the main agenda for the day. But before 9, we shall be recapping all the key issues and any questions that could have been left out as you move. That marks the end of our day 1 for the main conference. We thank you for having kept time and your patience to discuss. We look forward to see you tomorrow. Have a good evening. Thank you.